I'm Dr. Krishna Reddy. I'm a cardiologist. I was one of the co-founders of this care group of hospitals. It's about 12 hospitals with 2,000 beds in about 5 states in India. So from that tertiary care model, we are trying to develop into a outreach delivery models, mostly in urban communities and urban slums, as well as the rural villages. So my main purpose of visiting this was to share what we are trying to innovate in the rural healthcare delivery. Essentially, it consists of integrating a technology device, handheld device. Basically, it makes the health worker perform the same functions which a physician does in a primary health center. But at the same time, she is connected to the primary physician and guided by the primary physician. So there is no error in terms of the safety to the patient concerned. The technology permits the patient to have a patient ID through a biometrics. It also has medical record systems. And it has a simplified clinical decision support system. That means it will prompt the health worker to ask specific questions in terms of gathering the clinical information. When it is attached to certain point of care diagnostics, like say electrocardiogram or an electronic stethoscope, I can record the heart murmurs or the heart sounds. So that way she is able to gather the information which ideally a physician would have gathered. But at the same time, the same information is flowing back to the physician. And the decision support system narrows down the diagnostic possibilities for the health worker. So based on the narrow diagnostic possibilities, at least the basic counseling to the health worker can be done. Not only that, it has a printer which prints out the prescription given by the physician. So then she dispenses the drugs at the point of care. What it does is it eliminates the villager to go to the town. Because what we looked at is the money that they are spending, 60% of it is going towards the transport cost. So we are eliminating that one. And the rest of the money they are buying the spurious medicines in the pharmacies. So that we are eliminating by buying the generic drugs of quality control. So this is one on the delivery side. So we are trying to validate this delivery model, is it effective or not. For example, if today's antenatal care is about 20% of the women are getting antenatal care. Our idea is that by this delivery model, it should reach 100%. Or if today 15% of the patients have diabetes, what percentage of these are achieving standard of care? So this is ultimately trying to see the effectiveness of this delivery model. But more than that, it has to be self-sustainable. That means who has to pay for it? So for that, we are innovating on the micro insurance product. This is basically funded by the International Labour Organization. What it does is, because there is no insurance product for the outpatient care worldwide, it is for the inpatient care, hospitalization care. So this is the first product which is for the outpatient care. And not only outpatient care, it is for the primary and preventive care, because most of the insurance caters to the illness and hospitalization. Our belief is that if you focus on the primary and the preventive care, you can minimize the expenditure on the advanced hospitalized care. So this we are targeting at a cost of about $8 per family of 4 per year. So that means it becomes a self-sufficient model. But some of the workers may not be able to even pay for this premium. So what we are doing is we are partnering with a micro credit product. That means they give the credit to this person to pay the premium. So this is an innovative economic model. That means it has to be self-sustainable. And we are trying to monitor the cost effectiveness of this model. That means if we have to move from this 20% antenatal care to 100% antenatal care, or achieve this primary health care level, at what cost per person we are able to achieve it. If we demonstrate per person cost, then we can pitch into the public government that you take care of this cost. We will be providing the care to the patient. So this is what I think, in fact, most of the sessions in the morning today, they have been focusing on innovative ideas to make healthcare cost effective. Though it was relevant to the developing world, I think it has become more relevant to the developed world as well, like the US, where somebody said currently it is 70% of GDP and expected to go to 36% of the GDP by 2040, which no country can afford that. So we are trying to do it in a small scale of 200 villages involving 1 million population. Then we extend the same concept once it is standardized to 20,000 villages or 200,000 villages. That includes how the health worker is trained. So today we have a training content, then we are putting into a multimedia training modules. then ultimately the health worker should be self-learning modules. This is how we can train hundreds of health workers. And more importantly, we are not employing these health workers. They are self-employed entrepreneurs. They are not only performing this function, but they are performing very simple things, like they want to sell water purifiers to the villages. By itself, you can improve the health. They are selling the sanitary napkins. Okay. The key reason for the cervical cancer in the underdeveloped villages is hygiene of their menses. They don't take care of that hygiene. That simple thing like providing a sanitary napkin can improve a long way towards that. They're also selling, if you take the villages, the elderly villages, almost 60% of these people we have visual impairment because of just reading errors, refractory errors. So what this health worker does is she sells a reading glass to them at a very low cost. So that eliminates 60% of visual improvement. I mean, it does not require too high technology. So what we are trying to do is that, because as a delivery provider, a lot of technology is developing worldwide, but the technology is developing in isolation. Suppose somebody develops an application for iPhone and they try to find its application somewhere. So there are technologies which are already available. Our role is to integrate these disparate technologies. Somebody is working on, say, microhydraulics. It's a very high-end technology for point-of-care diagnostics, which give a drop of blood, a panel of 18 tests. So that technology, they don't know that it can be applied to masses. So our role is to integrate these disparate things. Like the handheld device, somebody device for some other purpose. But we try to integrate into our rural health care. So this is how, I mean, we are integrated. We are not innovating on the technology, but we are trying to integrate we are collaborating with the International Microincidence Agency, because they are experts in the microincidence problem. But they haven't applied that this can be applied for the primary health care. That is our role. Our role is to identify. Like the Grameen Muhammad Yunus, he started with microincidence, but he did not think of the effectiveness of the delivery system. He did not think through, because he is not a clinician. He did not think through the delivery system problems, because ultimately the delivery system has to be effective. Then comes the financing of the delivery system. So this is how I think we are trying to look at a comprehensive model. I won't say that we have succeeded. It has to be validated. We have to show ourselves that there is a change in the basic health parameters of these 200 villages that we are serving, that the patients are happy, and whatever these health workers are doing, it is safe. It is not compromising the safety of the patients. And the same concept can be extended multiple ways. It can be extended to the communities in the cities, the slums in the cities. It can be extended to the hands of the patient. That means each patient can have that handheld device and can have self-management. So I think these are, I won't know whether it is innovation, but definitely we are trying to do something slightly different, which has to be self-sustaining. It cannot be that you have a technology and it just applies, ignoring other components of the whole healthcare delivery system. So I think this summarizes what I was trying to present.